Andrea Kane from HSC 114. We are now into week number 5 in our medical terminology course. We're using the book, The Language of Medicine, 12th edition by Davy Ellen Chabner. So let's move on and see what we're doing this week. We are on chapter 11, which if you look at your syllabus, this is unit 7, the cardiovascular system. These are our chapter goals. They're pretty consistent with what we have done in the other chapters that we've looked at. And I think there's about 90 slides to this one, so we have plenty to study together. Let's go. The cardiovascular system delivers oxygen and nutrients to the cells of body tissue. The areas that we're going to talk about right now are the heart and the blood vessels. We'll talk more about blood itself, the different types of blood cells and all of that in the blood system coming up in a couple of weeks. In fact, I think that's week 6. So this week we do heart and blood vessels and the respiratory system, and then next week we get into blood, lymph and immune, and the endocrine system. So lots coming up here. The heart is a muscular pump. It's all muscle. So if you hear somebody say it's all heart, they're really saying it's all muscle. And then the blood vessels, those are your arteries and veins. They're fuel lines and transportation networks. Arteries are the vessels that lead away from the heart. They have the oxygenated blood in there. So when you think about arteries, you want to think that the blood is coming out, and it's coming out with lots of oxygen. The veins, they bring the deoxygenated blood back to the heart. So I guess if you think about arteries, they are leaving the heart and going out into the body, and the veins are your way back. So I think if you think of a vacation, arteries are the trip there. You can't wait to get there. Oh, it's exciting. Oh, you can't wait to get there. And then the veins are on the way back. You're exhausted. You're tired. Oh my goodness, you had such a great time. But you're ready to get home, and it seems like you'll never get there. That's that deoxygenated blood moving back toward the heart. Your capillaries are your smallest vessels, and that is where the exchange happens for oxygen and nutrients into the body cells, and then the waste products coming back out. And we talked a little bit about waste products in week 4 when we talked about the urinary system. And the week before that, or 2 weeks before that, when we talked about the digestive system. So here we are on blood vessels, and this is another really good visual for you to look at the capillary compared to a vein compared to an artery. Look at all those layers. All right, so how does the circulatory system work? Well, it involves the heart and the lungs, and that's why I put these 2 chapters together, is because the heart and lungs really, they're dependent on each other. They work together. If something's going wrong with the heart, it's going to back up into the lungs. If there's something going on with the lungs, it can negatively impact the heart. So you just need to think about these 2 being partners. They work together, sort of like a relay team. And they hand off the baton to each other through the blood. Blood leaves the heart. It goes up into the lungs. It picks up it gets rid of the carbon dioxide. It picks up the oxygen, and then it heads out into the body. And as it heads out into the body, it's going to give up all that oxygen in the capillaries. And it's going to pick up all the waste in the capillaries, and then it's going to head through the veins back into the heart. And from one side of the heart, it pushes to the other side, and then it goes back into the lungs. And so you can see how this circle works. The red is oxygenated blood. The blue is when it doesn't have oxygen. And hopefully this helps. Like I said, this is a really good visual if you need to think about how this works. And you do need to know that the blood comes in from the veins into the right side of the heart. And then it comes out from the left side. So just be thinking about those sides. This is the aorta and the arteries. So again, we're talking arteries. Blood is leaving the heart, and it leaves through the aorta. And then it goes from here to all these arteries. One of the worst injuries you can have is to have a cut artery. because the blood just keeps pumping out from the heart through the artery. And that's one of the quickest ways to bleed to death. If you think about war injuries, if somebody gets nicked in the femoral artery, they can bleed out incredibly quickly. And it's one of those unfortunate things in life. So this just gives you an idea of all of those and where they're located. So what is the anatomy of the heart? These are the structures. There's the superior vena cava, inferior vena cava, right atrium, tricuspid valve, right ventricle, pulmonary valve, pulmonary artery, pulmonary veins, left atrium, mitral valve, left ventricle, aortic valve, and aorta. The tricuspid valve, these cusps are the flaps of the valve. So whenever you think cusp, think flap of the valves. The tricuspid one is between the right atrium and right ventricle. And I'm sure they'll have an illustration for this, but I'm just going to go through it so that if you're marking down on index cards or flashcards, just kind of repeat this. But so your tricuspid valve is between the right atrium and right ventricle. Your pulmonary valve is between the right ventricle and the pulmonary artery. Your mitral valve is between your left atrium and left ventricle. Your aortic valve is between the left atrium and the aorta. And looky here, we have a visual. I was hoping they would. Anyway, you can see here how the blood comes in through the superior and inferior vena cavas and goes into the right atrium of the heart, goes through the tricuspid valve, through the right ventricle, goes over to the lungs, through the pulmonary artery. In those lung capillaries, the CO2, which is a waste product, is exhaled. The O2, oxygen, is inhaled. That oxygenated blood goes through the pulmonary vein to the left atrium, to the mitral valve, through the left ventricle, and out through the aorta. And then it goes out to the rest of the body. And then it comes back through the vena cavas. So think of the vena cavas as veins and the aorta as an artery. And that'll help you. So what is your heartbeat? It's made up of two phases. There's diastole, which is when your heart is relaxed, and there's systole, when it's contracting, when that muscle is contracting. The diastole, and I can't talk at the moment, sorry. The diastole and systole cardiac cycle happens 7 to 80 times per minute. That's normal. So if your heart rate is racing, it's going to be more than 80 times a minute. And if it's slow, it's going to be like 50, 60. Worst case, it'll be 30s and 40s. You definitely don't want to be down that low. So you want it to stay roughly between 70 and 80 times per minute. That means it's about 100,000 times per day that your heart contracts and relaxes. Can you imagine that? 100,000 times a day your heart contracts and relaxes. Now multiply that by the number of days you have lived. Is that not amazing? And think about how many more days you will live. I mean, I'm here hoping that you all have at least 80 years left. That's a lot. So it's amazing what our hearts can do and how the muscle is designed to be able to take that kind of wear and tear and get us through. But it's very understandable how people get into their 80s and 90s and they have what's called congestive heart failure, where their heart is not working as well as it did before. When you get to be 80 and 90 years old, you think of that 100,000 times per day. That's an amazing amount. Your heart pumps about 3 ounces of blood every time it contracts. So that means you're pumping 5 quarts per minute. That's 75 gallons an hour and 2,000 gallons a day. That's really amazing when you think about it, that you're producing, that through your body, you're pumping 2,000 gallons of blood a day. If you think of a gallon milk jug and you think about that, that's amazing. Heart sounds. What do they sound like? Have you ever gone to the doctor and had the doctor let you use a stethoscope so you can listen to your heart go lub dub 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 lub dub? Well, if you haven't, the next time you go to the doctor, ask them if, and even if it's a nurse practitioner or a PA, ask them if they will let you listen to your heart so that you can hear that sound and understand what that sounds like. The lub part of it is when your tricuspid and mitral valves are closing at the beginning of that squeezing, that systole, that contraction of the muscle. The dub part is when the aortic and pulmonary valves are closing at the end of that contraction. So the lub is when it's at the beginning of that contraction, and then the dub is at the end. Have you ever heard of a heart murmur? That is an abnormal heart sound caused by improper valve closure. And there can be a lot of heart problems detected when someone has a heart murmur. Sometimes heart murmurs are very minor and they don't really impact someone. But there's other times when a heart murmur can be an indication that there's something really wrong with the heart. So a lot of times, if a healthcare provider hears a murmur, they'll refer you on to a cardiologist so that they can really do some testing and make sure that your valves are opening and closing properly. Phases of the heart. Here's another really good slide, except that it's kind of fuzzy. I hope it's not terribly fuzzy for you, but on my screen it's showing kind of fuzzy. And this just shows you when the valves are open, what's open at the same time, what's closed at the same time. So if you notice, when your mitral and tricuspid valves are open, you've got the blood flowing into each of those ventricles. And when they're closed, when the mitral and tricuspid valves are closed, that's when your pulmonary and aortic valves are open and the blood's being pumped out. Hopefully that makes sense. All right, so conduction system, because guess what? There's an electrical component to your heart. Did you know that? And that's why they talk about electric shock. You know, somebody might have to have their heart shocked, or sometimes someone has an arrhythmia in their heart and it has to be adjusted. That's because of the electrical conduction system. So there's something called an SA node, sinoatrial node, and that's what paces your heart. Have you ever heard of somebody with a pacemaker? For whatever reason, their SA node has stopped functioning the way it's supposed to function, and so they have to have a small device inserted underneath the skin that produces the same electrical conduction as their normal sinoatrial node to be able to get that going. So it's the pacemaker, origin of electrical impulse causing the walls of the atria to contract and force the blood into the ventricles, and that ends diastole. So you had here an SA node. Notice that SA node. Now you've got an AV node, atrioventricular node, and this sends a wave, an excitation wave, to a bundle of specialized fibers called the AV bundle, or bundle of His. You can say bundle of His if you want, but it's His. Either way, His. It helps form the conduction myofibers that extend to those ventricle walls and stimulate those to contract to get systole going. And then you have a short rest period following. So hopefully we'll get an illustration on the next page that will help us with this. And then the pacemaker starts over again. So going back to the previous slide, your SA node is your pacemaker. The pacemaker sends a message to your AV node, who works with the bundle of His, think snake, His, H-I-S-S, and from there it goes through and stimulates them to contract and then rest, and then it starts all over again. An ECG or EKG, they're usually called an EKG unless there's someone saying an electrocardiogram, but sometimes people say ECG. It's a record of the electrical changes in your heart muscle as the heart beats. So you've probably heard someone say, oh, there's an abnormal EKG on this patient. At one point in my life, I had pulmonary emboli, and it caused me to have an abnormal EKG. And what it was is they were looking at it and they realized that my heart wasn't working the way it was supposed to in terms of these electrical changes. And they ended up doing a cardiac cath on my heart to just make sure there was no kind of blockage or issue with that. And it turns out then they went ahead and did the radiology tests to find out that that it was the pulmonary emboli. But you can see how the heart and the lungs, they work together, and if one is not working, the other one is going to be impacted. And this is a great way to identify if there's issues with the heart with the electrical changes, is that EKG or ECG. And here's what it looks like. This is just one small segment. Typically, they do several segments together on the same report so that they can see it over a period of time, because you see at the bottom it's milliseconds versus millivolts. So how do you read an EKG? There are waves. There's a P wave, there's a QRS wave, and there's a T wave. You want to see these waves, and you do not want to see them really crazy, and you definitely don't want to see them without. Have you ever heard someone has flatlined? That means their EKG is a flat line. That means their heart has no electrical conduction whatsoever, and technically they're dead, and you need to revive them or you need to pronounce them as being dead. That would be when you hear that phrase of a flat line. The QRS wave, you look at the distances, the height, how these work together, the ST segment, the length of that. That's a way you can identify an AMI, or acute myocardial infarction, which is known as a heart attack. They'll tell you it's an elevation in the ST segment. This type of acute myocardial infarction or heart attack is called a STEMI because it's an ST elevation myocardial infarction. And that's a very common kind of heart attack. It's pretty well known, but that's one of the ways that they can identify it. There's other types of heart attacks or myocardial infarctions. There is a non-ST elevation one too, but that's one of the things that doctors look at when they're reading these, is they look at all the different waves and the distance in the ST segment. So here's a little bit bigger slide of what we saw before, and another one. Okay, so let's talk about blood pressure. Many of you have thought about going into the field, and you'll probably learn how to take a blood pressure. Now this picture shows you the old-fashioned hand bulb pumped blood pressures. If you go in now, you probably see the electronic ones where they put the cuff around you and then they hit a button and it automatically pumps up. But this is an old-fashioned one. And the mercury level is what it measures those pressures, your systolic pressure, your diastolic pressure, and it's called sphygmomanometer. I can't even say it tonight. Sphygmomanometer, and it is a typical average is 120/80. So as long as you're not above like 125, over like 85 or 87, that's really normal. You don't want it to be too low either. If you're like 110/60, that is not good either. So just like we were looking at for your heart rate, your blood pressure can tell us if things are not going well with your heart. It's measuring the force that the blood exerts on the arterial walls. So we're up to vocabulary with meanings and definitions. And we've got the AV bundle, or the bundle of His. And you've got your AV node, Watch out for atrium and atria. Atrium is singular and atria is plural. So if you're doing flashcards, make sure you note that. And CO2, with a 2 there at the bottom, is carbon dioxide. Not carbon monoxide, that would just be CO, but carbon dioxide. Excuse me. And here are more. Endocardium, endothelium, diastole, myocardium. And this gives you, again, the normal sinus rhythm. One thing to remember as a healthcare professional is that you may have a patient that you're going to check their heart rate or check their blood pressure on. If they are nervous, it's going to come higher. Because think about it. When you get nervous about something, like right before a big test or right before, many of you play softball, if you're getting up to bat, your heart's going a little bit faster. So one of the things that it's good to do is when you get a patient, to talk with them for a minute or two and let them settle before you start taking their heart rate or their blood pressure, so they have a chance to kind of calm down and settle down. Otherwise, it may run high. If they don't have a normal tendency to that anyway, it might be hard to tell. And then we talked about the SA node, sinoatrial node, being a pacemaker. And this again talks about how the good old lungs and the good old heart work together. Septum and septa. Be aware of that Latin combination too. Septum is singular, septa is plural. I know I should pronounce it again. But if you want to hear the pronunciation again for an instrument to measure blood pressure, check out the Evolve website, will you? I have always had trouble with that one. Valves and veins, we talked about those. Again, good old Latin coming back at us. Vena cava is singular. Venae cavae is plural. And this one's kind of wild in that there's an E on both vena and cava in this example. That's kind of rare. So do make a note of that. You know, all of this is really good practice for those of you who are planning on taking biology or anatomy and physiology coming up. Your teachers will probably be pleasantly surprised by how much you know by the time you get there. Okay, so we're on to combining forms and terminology, and remember our equation. A combining root plus a combining vowel equals a combining form. And here are some to begin with. And note, right off the bat, we have 2 for artery. And here are some more. And more. Watch out for vein here, veno and veni. You've got an O and an I for combining vowels on that one, so be sure you make a note of that. What is the double-layered membrane surrounding the heart? Ooh, 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 you might have to run back to one of those visuals to take a look at that or check your book. Contraction phase of the heartbeat is called, we talked about this several times. Hint, 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 it is not vena cava and it is not septum. So you better get it from here. I know you can. All right, we're on to heart arrhythmias, pathology of the heart. So let's talk about that. What happens when your heart's not in the right rhythm and when things are not working the way they're supposed to? That there might be an electrical conduction problem. You could have something like heart block. You could have flutter. or fibrillation. I hear a lot about atrial flutter and atrial fibrillation back in the hospital world. And heart block is usually AV node block. So those are things you might run across. There are some types of congenital heart disease. These are things that develop in babies before they're born. They happen in the uterus, and it's amazing. You can look this up, but they are now able to do surgery on many babies while they're still in their mom's uterus to fix these kinds of heart defects. Sometimes they'll choose to do that. Other times they'll go ahead, let the baby be born, and then do surgery either immediately after birth or within a couple of days. So it's just incredible to think about how they can do all of this. Congestive heart disease. I referred to this earlier. When the heart is unable to pump the required amount of blood. A lot of the reasons why congestive heart failure happens is just age, old age. If you think about your heart contracting 100,000 times a day, then you multiply that by 80 or 90 years of life. It's no wonder at some point our heart just might say, hey, I'm getting tired here. I'm not able to pump as well as I used to. So that often happens, and that's just a normal, natural part of life. But there are patients who get congestive heart disease or congestive heart failure from other things. And I'm hoping that the slides will go into this a little bit further, but your book does too. CHF is often the result of high blood pressure and coronary artery disease. And we'll talk about what that means. It results in pulmonary edema. If your heart is not pumping out the required amount of blood or pumping it strongly enough, what do you think is going to happen? There's going to be some backup. And where's that backup going to go? And what's it going to do? You're going to get that fluid, which is what edema is it's fluid backing up. And it backs up into the lungs, which makes it harder to breathe. So not only is your heart not working the way that it should, but then your lungs are having to struggle as well. And a lot of times patients with congestive heart disease, they're given what are called diuretics, and that drains the fluid from their lungs. And so that you may notice if you have older relatives that are in their 70s, 80s, 90s that have a little bit of a touch of congestive heart failure, they have to go to the bathroom quite a bit, and they take certain pills every day. Lasix is one of them you may hear about, and that causes them to have to run to the bathroom because it's that fluid, that pulmonary edema is finally gotten out through the waste process through urine. It is fatal. Congestive heart disease is fatal if untreated. It's also fatal because it can reach an end-stage disease point where the person has so many problems and their heart is not functioning and they're not a candidate for a heart transplant. There are people who do die of congestive heart disease. And it may be the fluid backing up. It may just be that their heart quits working. So let's talk about coronary artery disease, or CAD, coronary artery disease. You can have atherosclerosis. Atherosclerosis. That one I actually can't pronounce today. So hoo-hoo for that. Thrombotic occlusion, ischemia, necrosis, infarction. Atherosclerosis is basically a buildup of plaque in your arteries, your coronary arteries to be specific. And some of the ways that they do that are, have you ever heard of the phrase Roto-Rooter? It was a company that used to do some unpleasant plumbing work, shall we say. If someone had a backed up drain or a backed up toilet or a backed up sewer line, a company called Roto-Rooter would come in with their equipment and put their equipment down and basically push through whatever blockage was there. Well, They've developed the same process over the years for people who have coronary artery disease with atherosclerosis. You can have a cardiac catheterization where they go in and they essentially scrape out, push through a blockage, scrape it out, and then they put in what's called a stent, S-T-E-N-T, a stent. And you may have heard that as well, to try and open that up and keep it open. Ischemia is when the blood is not flowing as it needs to. Necrosis is death. When you think of necro, think of death. And infarction is that heart attack. It's a complete stoppage, so to speak. So you can have acute coronary syndromes. There's unstable angina. Notice the difference there, unstable angina. There are some people who pronounce that angina, but I've always heard it pronounced as unstable angina. So you might want to pronounce that yourself, angina. Myocardial infarction, we talked about that earlier, is a version of heart attack. So coronary artery disease, what do you do? There are drug therapies, lots and lots of drug therapies. You may have heard of somebody who puts nitroglycerin under their tongue. The nitrates in that help with chest pain and easing up some of the constriction. Aspirin is a blood thinner. Many people choose to take an aspirin a day, a baby aspirin a day, and it keeps their blood thin enough that it keeps moving through. I know people who have a tendency to have blood clotting, and often they will take a baby aspirin a day, and it just keeps their blood flowing. It keeps it from clotting too much. Beta blockers and ACE inhibitors and calcium channel blockers and statins, those are all things that are used to treat the different types of coronary artery disease, or the different causes, I should say, whether it's high cholesterol or whether it's high blood pressure, those types of things. There are also surgical therapies for coronary artery disease. There is something called a CABG, and you will hear of cabbages in the healthcare field. They are not the kind of cabbages that you make coleslaw out of or sauerkraut. These cabbages are coronary artery bypass grafting, and they're typically done in big teaching hospitals, big major medical centers, trauma centers. And that's where they go in, they take an artery out of somebody's leg and they move it up and they put it in their heart to bypass the artery that is blocked. So if you hear somebody who had a triple coronary artery bypass, that means they took out 3 arteries from somewhere else in their body and they moved them up and they put them into their heart to bypass where there was a blockage. So they now have 3 veins that go around. It's sort of like with a highway. If you have a huge pileup on the highway, you start seeing which exits you can direct traffic off of to go around the accident. When it comes to blockages in the heart, sometimes the cardiac cath with the removal of the blockage is just not possible. Maybe it's completely blocked, or maybe it's blocked significantly or at a very tenuous point that can't be, it's at a really bad spot where you can't go around it or you can't get through it. So you're going to have to bypass it with a graft. And so that's that situation. Percutaneous coronary intervention, PCI. I'll let you look that up if you're really excited about that. But that's percutaneous coronary intervention, or a PCI, is a fancy way for saying cardiac catheterization, or, with or without stent placement. Other pathologic conditions of the heart: endocarditis. Endocarditis, inflammation of something. And you should know what the endo and the card are. That's often from an infection, and the infection causes what are these growths called vegetations, and it's a very serious condition. Patients require a lot of treatment. They can die from it, but for the most part, people with endocarditis, if they don't have anything else wrong with them and they're hit with the right combination of antibiotics and care and treatment, they do just fine. But it's certainly not anything anybody wants to voluntarily sign up for and say, ooh, I'd like that. It is very serious. Hypertensive heart disease. Hypertensive, what does that mean? High blood pressure is causing heart disease. Mitral valve prolapse. You can have a droopy mitral valve, and a droopy mitral valve is not a good thing, and that can happen. Heart murmur. Pericarditis, again, inflammation of the what and what. Peri and card, you know those from before, so you should be able to figure those out. And then rheumatic heart disease. People can have rheumatic heart disease. A lot of elderly people who have rheumatic heart disease may have had scarlet fever as a child. Scarlet fever, if you think about it, and you go back, strep throat is caused by strep as a bacteria. If it is not treated or not effectively treated, which again, think about when penicillin came into being and when it was readily available to treat people. If it wasn't treated or not effectively treated, strep throat goes into scarlet fever. Scarlet fever, one of the ugly sides of that are that it has the potential, if it's not treated quickly and effectively as well, can cause what is rheumatic heart disease. So that lovely strep bacteria is some nasty bit of work, and it has a role in rheumatic heart disease. Blood vessels, you have blood vessels, yes, and things can go wrong with them. With blood vessels, you could get an aneurysm. You could have a DVT, deep vein thrombosis. You could have hypertension, high blood pressure again, peripheral vascular disease, Raynaud's disease, and varicose veins. Well, let's talk about these. An aneurysm, that's where basically you get a bubble forms. And the bubble is part of the vessel. So it starts collecting blood and it gets bigger and bigger and bigger, and then it decides to pop. And you always hope that if an aneurysm starts, that it's found before it ever pops, and that it can be dealt with before it pops, because once it pops and it hemorrhages all that blood all over, it's a race against time to try and get it stopped and fixed and save someone. You may have heard of someone who had an abdominal aortic aneurysm, AAA, abdominal aortic aneurysm. Oh, those can be very fatal. And sometimes the symptoms for those can be silent. Somebody may not even know they have it. Oftentimes they identify these sort of as a, oh, whoops, we found it, while they're testing for something else. And then they just monitor the person periodically every couple of months to make sure the aneurysm is not growing or dangerous. Deep vein thrombosis, you may have heard of that. DVT, it is a blood clot in one of your leg veins. And blood clots in a leg vein don't sound like they're that serious, but they have been known to break off. The clot has been known to break off from where it is in that vein and go up and lodge itself in the heart and cause major problems in the heart. So they are very, very serious. And if someone has a DVT, it can end up in their heart, it can end up in their brain, it can end up in their lungs, all of which are very, very serious. So somebody with those symptoms definitely needs to go get checked out sooner rather than later. Hypertension, we talked about high blood pressure. If you think about it, if your blood pressure is way too high, how much extra work is that adding to your heart? And how much pressure is it putting on your arteries and on your arteries specifically as it's pushing that blood out of the heart? So you can see that how if you're pumping, if you're contracting 100,000 times a day and you have high blood pressure, how over time that can cause issues. Peripheral vascular disease, that happens where, well, what's a good good way to explain this. Your blood vessels are not handling the blood the way that they need to. It's not getting all the way where it needs to go to do its exchange and come back. Maybe your vein has stopped working, maybe your artery has stopped working. It's just, it can cause a lot of problems. Sometimes they can get grafts again. They can borrow a vein from one leg and put it in another leg to handle it. But people who have severe peripheral vascular disease, that's another really serious one. They could actually end up having a limb amputated or something else very serious. I'm going to let you look up Raynaud's disease and see how you want to do that. And I'll also let you take a look at varicose veins. Let's move on to the next one. Which arrhythmia refers to rapid, random, inefficient, and irregular contractions of the atria and ventricles? Are you getting lots of beats or more per minute? I'm going to let you think about that. I can tell you for sure it's not C, bradycardia. Brady means slow, right? Okay, so let's talk about lab tests. Give me just a second here. All right, so there are different tests you can do. There's a BNP test. I'll let you take a look in your book for more information on that. Cardia biomarkers. Again, check your book. Lipid test profiles. There's all sorts of tests they can do to check your lipids or your fats in your blood and what those will tell you about the situation with your blood or your vessels and things like that. Lipoprotein electrophoresis. Again, I'm going to have you take a look at that on your own. So, clinical cardiology procedures, looking at diagnostics, there are angiography and arteriography. There's CAT scans. There's something called DSA, digital subtraction angiography. There's EBCT or EBT. I've seen EBT more often than EBCT, but electron beam CAT scan, essentially. Ultrasound test, Doppler ultrasound is often used. Again, think about how bouncing sound off those structures of the heart, what that can tell us. And then echocardiograms, those are very often done to take a look at the heart. They can tell just a myriad of things. And again, that's probably in your book. Nuclear cardiology, oh, we think about nuclear medicine and think about those lovely things. There's PET scans. There's what's called a TCM99M scan and a thallium. I have most heard about the thallium being used when nuclear cardiology is involved. And, you know, you've got the radionuclide and the thallium, and you can look up more on that if you're interested. And then, of course, there is a cardiac MRI. There's cardiac catheterization, talked about that. That's where they go in, usually through the groin artery and snake on up. And then they go through and they visualize what the arteries look like. Is there a blockage? Is there no blockage? Does there need to be a stent put in or not? Do we need to clean out the artery? Those types of things. That's typically done as an outpatient procedure, which is amazing if you think about it. ECGs, EKGs, Holter monitoring. The Holter monitors, they actually hook you up and it measures you over a 24-hour period, sometimes longer than 24 hours, but it's a longer period of time where they're measuring what's going on with your heart. And then stress tests. And that's where you're on you might have heard of a treadmill stress test, where they get you on there, they get you moving, and they're testing you and testing your heart as you're exercising. Okay, so what else is there? There's cardioversion. I mentioned that earlier. Defibrillation. Cardioversions are when they need to switch your heart rhythm. It's not in the right rhythm. They need to switch it. It's called cardioversion. They can do it chemically through medicines, drugs, that sort of thing. And they can also do it through electronic means with sort of shock. So there's those two types. There's an endarterectomy, and if you break that down, you'll figure out exactly what that is. There's extracorporeal circulation. When somebody's getting a cardiac bypass, a cabbage, they're usually put on extracorporeal circulation because you're messing with the heart at that point. You still need to get the blood moving and oxygenated and that sort of thing. Heart transplants. Yes, heart transplants are very possible in this day and age. It's all about finding the right donor, though, and doing it while someone's still in a condition that they can have a heart transplant. Because it's tough to find a match in the right frame of time. Thrombolytic therapy. You've got those blood clots and you're trying to get rid of them. And so you may have heard of heparin, warfarin, those types of things. Those are medicines that thin your blood. They keep it from clotting. Transcatheter aortic valve replacement, TAVR. That's another procedure that can be done. And there are lots of procedures when you think about with the valves. There's all sorts that they've developed. This is a good visual for cabbages. If you're wondering about how they do the cabbage, come back here and take a look and read through it. This is the PCIs, the percutaneous coronary interventions, which is essentially angioplasty, cardiac catheterization, those two. And this just shows you how they do the stenting. What it is that you see, there's the plaque there, which is building up. They put it in, they expand the balloon to shrink the plaque, to open it up, and then they inflate the stent. The stent's there, and then they leave the stent, and the stent is hopefully sturdy enough to keep the plaque from building back up again. Not forever, but hopefully for a while. We're on to abbreviations and their meanings, and there are lots and lots here. I'm not going to linger over these because you can come back when you do your flashcards and go through them. So I'm just going to kind of keep flying along. There's a lot to cardiology. And as I said before, there's the link to respiratory as well as to blood. And as we keep moving forward and studying, it's amazing to see how all these systems are so interrelated. You can understand how if one is not functioning ideally, it's going to have an impact on another. The heart impacts the urinary system too, if you think about how getting rid of those wastes and that type of thing. So which procedure involves insertion of a balloon-tipped catheter into a coronary artery? Everybody should get this one because we just covered it. Hint, hint, hint. All right, and combining forms and their meanings. Remember our equation. You have a combining root plus a combining vowel, and that will equal a combining form. And I already mentioned about artery having a couple of different spellings there. Now we're into some suffixes. Note some of these. And yet more suffixes. A few prefixes. And we are done. How did that happen? All right, I will see you soon for the next lecture, and it will be on the respiratory system. Have a great afternoon or evening or whatever time of day this is for you. Bye.